All right, so welcome to week 4. So we are going to start, we have our quiz. So I will give you your password for your quiz. After your quiz, you can go ahead and turn your quizzes off, or turn your cameras off until everybody's done. And then we're gonna go over the case studies, and I've got a little bit of lecture.
Let me call you right back. I'm fixing to take a quiz, okay?
A little bit of lecture afterwards. Sam, I'm gonna go ahead and mute you, okay?
Oh, I thought I was muted.
No.
Okay, so your quiz or your password is in the chat. Good luck. You guys are gonna do great.
My quiz still
My
says
quiz says it's locked until January 30th at 12. Sorry.
that. No, you're good. You're
It
good.
does. It says that on mine too.
Mine says the 29th at 9.
Yeah.
Nope, this one says 30th at 12 a.m. and it's only open until the 30th at 12:30.
On quiz
mine
2,
says
Tammy?
11.
Are
Mine-
Mine
Your
says
quiz
2.
2? Yeah, mine says 11:29 and 9.
Nope.
Mine says 29 at 9.
Yep.
Mine also says
Here,
9.
this is what mine says right here.
It could be
Are you in the right show? Are you in community?
Yeah.
Yeah.
They all say that.
Yeah. I went
Mine
back
says the
twice
same
and checked it.
Yeah,
And
it
it's
says
9 o'clock,
too.
Dr. Martinez, and it's still not even generating for us.
Yeah, mine says, yeah. You get a 10, you get a 10, you everybody get a 10.
Okay.
I could use that 10.
Just saying.
Okay, try again.
Mine's
It is
still
the 29th,
mine's still
right?
locked.
Yep, mine's still locked too.
Mine's still locked too.
all locked.
Okay, now try it.
Nope.
Who can get in?
No.
No one can get in.
Nobody.
No.
Mm-mm. Mine's still locked.
This happened with my OB class last week. And then we only had 5 minutes to take the quiz.
No, I won't let you have 5 minutes to take the quiz.
I was gonna say, please don't do that to me.
I'm not. All right, refresh. Because it has to be a glitch on Canvas's side. I'm not sure.
Yeah,
what's
it's
going on.
not popping
It's
up.
still
Professor.
locked. Yeah.
Okay. Hold on. I'm working on it, guys. Give yourself like 5 minutes to study. Okay, refresh and see if you can see it now.
Yes.
Yeah.
Okay. Password is the same.
The same. Okay.
All right, guys, come on back. You guys did really good. Good job. Um, so we'll go over the quiz real quick. I'm just trying to figure out why there it is. Before I do, does anybody have any questions about the quiz? Nobody wants, okay. Okay, so what statements would indicate a lack of understanding regarding an appropriate reason to sue for professional negligence? What is negligence?
Care or lack thereof that directly results in injury to an individual.
Okay, all right, and there have to be like key components, right, in order for someone to be charged with negligence, right? If they are claiming negligent behavior, right, they have to be able to prove that the nurse owed a duty to the client or was responsible for the client's care, that the duty to act in a way reasonable, prudent nurse would act in the same circumstances was not fulfilled. The failure to act responsibly under the circumstances was not fulfilled. Not the failure to act reasonably. And then the injuries provided a basis for monetary claim from the nurse's compensation for the injury. So the lack of understanding regarding the appropriate right, not given a call bell. Whereas that's, standard practice, make sure everybody has their call bell in reach, right? It's not truly negligent behavior. What are some of the roles or what is the role that's central to the parish nurse?
Spiritual and dimensional care.
Spiritual dimension of care. Very good. A father confides in you that his wife has been hurting their child. What is the first step that you should take?
Report the findings to Child Protective Services.
Right, we're going to report those findings. As nurses or healthcare professionals, all healthcare professionals, we are all mandatory reporters, right? So if we know or suspect that there is abuse, it is our duty to report. What aspects of a home health agency would most likely be examined during the accreditation process? So when they're coming in to look at a home health agency, what are some of the things that they are going to look for in a home health agency?
Well, I only got partial credit for this one, so. But
Okay.
I put organization of structure,
Mm-hmm.
outcomes of care.
Mm-hmm.
I wasn't for sure of history of clients, but I put it, and I don't know, so I don't know.
Compliance with Medicare would be the other one.
I thought so. Okay.
Yeah. Yes, so when we're looking at accreditation, we're not necessarily looking at the credentials, or they're not looking at the credentials excuse me, of the personnel rather than the structure, the outcomes, their compliance. Migrant farm worker report presents to the clinic and reports acute onset of dizziness, intense thirst, vomiting, fatigue, and headache, which could cause those symptoms.
Pesticide poisoning.
Yeah, that's your pesticide poisoning. Tertiary prevention related to pesticide exposure. What could we do? What's tertiary? What would be a tertiary?
Treat the
So it's
pesticides poisoning.
Right, we're gonna treat
Treatment.
them. I'm sorry.
I said it late. I'm sorry. I said treatment.
Okay, no worries. It's all good. Um, a teenager comes in for her prenatal visit, appears to be about 6 months pregnant, which following best describes why the teenage girl has waited so long to come in. Why do you think she waited? That's the hard one, right?
Where the parents would like make her make a decision to keep it or not.
Mm-hmm.
Wishing it would go away.
Wishing it would go away, right? It's a mistake. I'm not really pregnant, right? This is like a figment of my imagination. Yep. And then dreading the exam.
But this is my question. Why are we as nurses trying to guess what her parents will like? Why are we guessing why she will wait 6 months rather than just us just going on ahead and trying to treat her for the duration of the pregnancy?
What do you mean? Say that again.
Like, in other words, why, like, in other words, and not to sound harsh, but like, why would we care why she waited rather than versus us just trying to treat her and educate her and move forward with like interventions and stuff?
Oh, I mean, we are. It's just understanding why she didn't come in for her, like earlier in her pregnancy to start her prenatal care. It's just to have an understanding of why they would wait. We're not going to ask her, right? Because then that'd be counterproductive, right? We're not going to say, well, how come you waited this long to come in? I mean, you can ask in a less direct way, I guess. But it's just having an understanding of a teenage mind, an adolescent mind, what goes through their minds before, why they may delay. Anybody watch that show, 16 and Pregnant? Yeah. So, um, and there's still, there's that fear too, like, at 16. So here in Virginia, so unfortunately, I know well, not unfortunately, I know the laws here. When I was working in peds, I had a really long discussion with my provider one day because I was really curious about something. So we had a young lady, she had had a daughter or a son, she had a child. She was 16 and she brought the child in. I want to say the child was in for like their 4 month or their 6 month well baby check and get their shots, that kind of thing. And she asked if she could get, I want to say it was her flu shot. And I was like, yeah, I don't see why that's a big deal, right? I do have to ask the doctor first, right? So I go ask him, and he asked me, well, is her mom here? And I said, no, her mom's not here. And I was like, but she has a kid and she's signing for her kid to get shots. So it's just a really interesting dynamic, whereas she's that child's legal guardian and she can sign for him to get his or her injections, but yet she, being under the age of 18, was still not responsible for herself. So a parent would still have to sign permission to get a flu shot. I thought that was super interesting. And then the last question was, any questions about the math question?
I had the math and ran out of time.
I saw your message. So yes. And it was correct. It was correct. So that everybody did pretty well. Good job. Any other questions?
What was the answer to the math question?
It was 7.2.
Thank you.
You're welcome. All right, so there was two case studies that were in the discussion. One was on hypertension and the other one was on substance abuse. So let's go through the hypertension case study. Everybody get a chance to read and look at it and fill it out. Yes, no, maybe.
Yes.
Okay. Well, we'll start with hypertension. All right. So tell me about hypertension. What is hypertension?
A chronic
blood
disease
pressure.
characterized by high blood pressure.
Say that one more time.
A chronic disease characterized by high blood pressure.
Okay. And what do we consider high blood pressure?
140s over 80s or higher.
Okay. Usually 140 over 90s or higher. Okay. So if I go to the doctor's office today and I get my blood pressure taken and it's, 145 over 90, does that give me hypertension?
No, it has to be two separate readings at two separate encounters.
Okay, awesome. What are some of the causative factors for hypertension? Somebody other than Amanda.
Just your dieting, obesity,
Like lifestyle, like if you're
sedentary lifestyle, yeah.
Family history.
Environmental.
Mhm.
Smoking, alcohol consumption, chronic
Stress.
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 Ather's, I can't say that, where you get a lot of fat in your arteries, atherosclerosis.
Okay. Okay, so it can be genetic, it can be physiologic, lifestyle factors 100%, right? We also know that there's primary hypertension, there's secondary hypertension. What's the difference between primary and secondary? And that's with any disease, not just with hypertension. There's usually a primary and a secondary. So what's the difference between primary and secondary?
secondary, other organs are affected.
Primary is idiopathic and typically there is no known cause to it. It just kind of shows up.
Very good. So primary is idiopathic. You have it, we're not quite sure. Secondary is usually caused by another medical condition, right? So, if it's the kidneys, if it's the liver, if it's something else that's causing that hypertension. And if we fix the secondary cause of the issue, right, it usually will go away, right? Think gestational diabetes, right? What happens? You have gestational diabetes, right? You have a baby, guess what? Diabetes usually goes away. Yes, you have an increased risk for type 2 as you get older, as time goes on. But generally speaking, we've eliminated the problem, right? And gotten rid of the cause. All right. What else? So what are going to be some of your prime priority assessments for somebody that has hypertension? Say you're meeting them for the first time. What are some things that you want to do?
Medical.
So we're gonna,
Go ahead. Jackie, were you answering?
no, I was just gonna say, we're gonna do a full assessment, check blood pressure, heart rate, respiratory, lifestyle habits, stress levels and stuff like that.
Okay. So you said we're going to check their blood pressure. What are we gonna do? How are we gonna do, explain blood pressure to me? How are we gonna check it?
When you say how we going to check it, you mean like with blood pressure cuff monitor? I mean, like systolic over diastolic?
Okay, so all right, so you're gonna do their blood pressure, one arm or both arms?
One arm, and usually the arm closest to the heart, the left arm, if they don't
Okay.
have anything going on or no dialysis or anything.
Okay. When we're doing an initial assessment for somebody, if we're just meeting this person, whether we know they have hypertension or not, we're going to do both blood pressure in both arms, and we want to check to see if there's any differences in that blood pressure. We're also going to do orthostatic blood pressures. How do we do orthostatic blood pressures?
You do it in 3 different intervals, once laying, one
5
sitting,
minutes
one standing.
apart.
Okay, so lying, sitting, standing, and we are also looking for significant changes, right? Not significant. Usually they're not too significant. You can notice them right away. Tell me about using a blood pressure cuff. How do you know what size to use?
You follow the measurements on the cuff itself.
Okay, so using the correct size blood pressure cuff, too small or too large, right? We're not going to get an accurate reading. What about patient positioning when we're taking a blood pressure?
Their legs can't be crossed.
Okay. Right, sitting or standing or not, well, whether they're sitting, they're laying, they're standing, right? We want them in a straight position. We don't want their legs crossed. Want their arm relaxed, right? We don't want them tensed up. What are some symptoms of hypertension that we may ask our client about?
Headache,
Changes
dizziness.
in vision.
Headache, dizziness, vision changes. What else?
Chest pain.
Do you
Chest
have a
pain.
history of high blood pressure?
Okay, history of high blood pressure. What else?
Shortness of breath.
Okay.
Redness.
Um,
Weakness.
Blur vision.
blurred vision. Very good. What are some genetic or we'll just go with genetic. What are some genetic risk factors for hypertension?
Race.
Okay, which races are at the highest risk?
African American.
African, Hispanic.
Okay. We also want to ask them about other diseases that may have going on with them, right? And then did we ask about lifestyle? What are their stresses, right? Nursing students don't have stress, right? You guys don't have any stress, right? But right, what, is it family stress? Is it life stress? Is it work stress? What's going on? What are just their normal activities during the day? Height, weight, BMI. What is obesity BMI? I'm sorry, that just came out wrong. What is the BMI to classify somebody as obese?
Over 35.
30. All right, what else? Do they smoke? Do they drink? How much exercise do they get? What's their usual diet? Is it a lot of fatty and processed foods that are high in sodium? So those are all things that we want to look at. What kind of lab tests would we do?
A lipid panel. An electrolyte panel for sodium and potassium serums.
Okay.
And then you would also want to do a kidney function test.
Yeah.
A BMP, CMP.
Right. So that, your electrolytes and stuff, right? We can do all that within the BMP or the BMP and the CBC. Lipid profile, absolutely. BUN and creatinine for your kidney function. Absolutely. Urinalysis as well. That'll give us a little bit more information, see if the kidneys are being affected by their hypertension, because we know that the kidneys, usually are going to be the next organ involved. What about an EKG?
Definitely.
I saw all the heads were like, yeah. All right, good job. All right, so
Have chest pain, you'd want to do like a trope and a CK.
say
If they have chest pain, to add a trope and a CK.
right, if they had active chest pain, right, we would definitely want to do that. All right, so what are some priority interventions that we can do for somebody that has hypertension?
Maybe
Basically,
salt and nutrition.
Okay, limit salt.
educate them
diet.
on,
Oh,
Go
my
ahead,
bad.
Jackie.
I said to consult a dietitian,
Okay.
not limit salt.
Consult the dietitian, not look. Okay, gotcha. Have you guys heard of the DASH diet?
Heart healthy.
You've heard of the DASH diet? So what is the DASH diet?
Low sodium, like for cardiac patients.
High fruits and vegetables, right? Low fat meats, low fat milk products. Watching the added sugar in some of the foods as well. Exercise, if they're overweight too, we're looking at weight reduction. What else?
Medication adherence.
Medication adherence, absolutely. What else?
lifestyle modifications as well,
Okay, so what kind of lifestyle modifications?
exercising.
Drinking, smoking.
Yep. Slow down the drinking, quit the smoking, right? Definitely want them to stop smoking. Even a significant change or a significant decrease in alcohol intake and cigarette intake or smoking can have positive effects. Of course, quitting is the ultimate goal. Getting them up, moving, right? Getting the blood flowing, all the exercise. What are some in potential or actual complications that can arise with hypertension?
Stroke.
Kidney
Stroke,
disease.
heart attacks.
Heart attack.
Kidney failure.
Organ damage.
Failure.
Okay, stroke. So they could have either we can have a hemorrhagic stroke, right? From, a blood vessel burst. We could have an ischemic stroke as a result of a blood clot. What's a hypertensive crisis?
Where it
Uncontrolled blood pressure as it continues to rise. It needs IV antihypertensives in order to be controlled, and the patient would need to be monitored overnight while they're in the hospital.
Okay, so a hypertensive crisis is exactly somebody has hypertension and medication, has not been effective and they already have evidence of secondary organ damage, right? So they have to be admitted. They are going to be given IV medications and monitored. On the other hand of that, a hypertensive urgency, that's someone that comes into the emergency room, they don't have any evidence of, other organ damage. We can usually monitor that on outpatient. What about my kidneys?
You'll be looking at kidney damage,
You'll be looking at kidney damage.
which could then end up continuing on towards chronic kidney disease and then end-stage renal disease due to high blood pressures.
what are some nursing implications in those situations? So, all right, so
Controlling of
let's
their blood
say,
pressure.
go ahead.
I would say, monitoring, of course, but like controlling the blood pressure, trying to keep it, within parameters. I don't know, I can't think off the top.
So one of the, how about, so I was working with a patient the other day, and he, was asking me like what medications he was taking, and I was telling him if he was taking like metoprolol for high blood pressure, he was also taking lisinopril, forget what a couple other medications not related to blood pressure. And he goes, what are these for? And I said, it's for your hypertension, or I told him your high blood pressure. He goes, I don't have high blood pressure. And I said, well, at some point you had a diagnosis of high blood pressure, right? In order for, to be on these medications. And he's like, well, every time they come in and take my blood pressure, it looks good. And I said, because you're on medication to keep your blood pressure low. Um, so one of the biggest things is, it's just, yeah, if the medication is working and we're keeping that blood pressure low, right? That's the purpose of the medication, right? Doesn't mean you just stop taking the medication. What is one of the things that can happen if somebody stops taking their blood pressure medication abruptly?
Rebound effects.
Right, rebound hypertension. Don't want that to happen. All right, so we'll talk a little more about medications. So what are some priority medications? Tell me about HCTZ. What is HCTZ?
Hydrochlorothiazide.
Very good.
The
What is
diuretic.
hydrochlorothiazide?
It's a
The
diuretic.
Very good. Tell me about some of the side effects or adverse effects of HCTZ.
Dehydration.
Hypotension.
Hypotension, okay, especially orthostatic, right?
Potentially like a drop in the patient's potassium level because they're just dumping it off.
Absolutely. What are normal potassium levels?
3.5 to
4.5.
5.2.
3.5 to 5.
0.5 to 5.
Stick with 3.5 to 5. Very good. So what can we tell them to help maintain those potassium levels?
Eat greens, like leafy greens or bananas. Diet.
Right? Eat some additional potassium in their diet. All right, good job. Tell me about beta blockers.
Don't give them to an asthmatic
Don't give them to an asthmatic. Awesome. Why?
because it will cause them to have vasospasms or bronchial vasospasms and cause them to have a asthma attack.
Okay, they cause bronchoconstriction.
Yeah.
Okay, very good. All right. When should I not take my beta blocker?
If you have low blood pressure, like
Okay.
Low heart rate.
100.
Describe a low blood pressure and a low heart rate.
Blood pressure lower than 90.
Under 60.
90 over 60 or a pulse less than 60. Good job. All right, what about my ACE inhibitors?
You can't, is that the one you can't give to African Americans because they're not like responding to it, or
Or ACE inhibitors are generally not first line for African Americans, correct?
Is that the one to give you a dry cough?
Dry cough, right?
Sonofrit.
That dry cough. It's not dangerous. It's not going to cause any issues. It's just annoying. What else about our ACE inhibitors?
Oh, it's
Is
an
that
angioedema.
Angioedema, yes. Something we need to warn our patients about, right, when they're starting that medication. What about calcium channel blockers?
Are those the ones that are more effective in African American clients?
Yes.
Yeah.
I don't know anything about that.
So it's always
It's been
just good.
so long.
Say that again.
It's been so long since we've went over it.
Yes, but pharmacology is everywhere. It is
Hypertension.
everywhere. So anytime you're giving a medication that's going to potentially affect the blood pressure, right? We always want to monitor for hypotension or orthostatic hypotension. Remember that our blood pressure medications are not one size fits all, right? So I give Kristen a dose of atenolol. She may not react the same way as Maddox does to atenolol, right? And so it's, we do diet and exercise first. Then we're going to add, usually a diuretic is going to be the next in conjunction with that diet and exercise. And then we will add those blood pressure medications as we need. Each group of your antihypertensives, your beta blockers, your ACE inhibitors, your calcium channel blockers, they all act in different ways within the body, right, to produce a different type of effect. So got him, he's had his crisis. We've got his priority medications in line. Now we're getting ready to discharge him back home. What are some patient teaching, some discharge issues that we want to address when they're leaving?
How to measure their blood pressure.
How to take their blood pressure. Awesome. What else?
Education regarding their medications and potential side effects like orthostatic hypotension.
Very good.
And
Right.
and if they're like still on a diuretic, time of day to take it. Don't take it at night so they're not up all night.
Very good.
Signs and symptoms of hypertension crisis. Hypertensive crisis.
All right.
I would tell them to exercise if they're able, like 5 times a week for 30 minutes, work on their stress management, and also like make sure that they're actually complying with their medications, that they don't just take them when they feel like it.
So what are some reasons why people would be non-compliant with their medications?
They're
They start
they
feeling
just
better.
feel fine.
Yeah, they start feeling better.
Okay. They start feeling better and they're like, oh, I feel better. I don't need to take this medication. What else?
They forget.
They forget, right? Especially if it's new, right? Oh, I've never had to take a pill in the morning before, and now all of a sudden I do, right? I forget. What else?
Medication
They
costs.
have the money. Cost.
Yeah.
They don't have the money.
To pick
That's
up their
a big
prescription.
one. It's a big one, especially with our older population, right? They might start to share some medications instead of taking them. Side effects is another one. Side effects of medications is another one. Think of, maybe not here, but think of, your anti-cholesterol medications, especially in men, they run the risk of, impotence and stuff taking those medications, which increases the risk for not taking them. If they have to take a pill more than once a day, that's going to decrease compliance, right? It's easier sometimes to remember to take a pill one time a day than it is to take it 2 or 3 times a day. So, looking at ways to, simplify their medication regimen, so that it is easier. And we can do things like, tell them to set, an alarm. Everybody well, not everybody, but most people have a cell phone, right? Set an alarm on their cell phones when they're supposed to take their medications. All right. Any questions? You guys did great. All right, so the second one was on substance abuse. So tell me about substance abuse. What is substance abuse? Maddox, tell me what substance abuse is. You're on mute, Maddox. All right, somebody tell me what substance abuse is.
I have excessive use of psychoactive drugs such as alcohol, pain meds, or illegal drugs leading to physical, social, or emotional harm, overindulgence, or dependency on addictive substances.
Okay, very thorough definition. Awesome. Um, and it could be legal substances too, right? It's just not illegal substances. The symptoms that they are going to experience is going to depend on what substance they're using, how much they're using, how long they how long they've been using. I'm trying to think what else. What are some etiologic factors when regards to substance abuse?
Like anything on the ACE test, the adverse childhood experience test, is that what you're asking? Like
No,
what would
like what? Well, yeah, I mean, that would be something, but what are some causative factors?
Abuse, trauma, family history, multiple family
Genetics.
members that have a abuse issue.
Okay.
Mental health issues.
Environment.
Chronic pain and inability to make it to their pain clinics.
Okay. Genetics is a big part of it too. Environment. Environment is, where you live, where you grow up, what your circle is like, so to speak. In some cases, it even has some cultural cultural background as well. What affects in the body? Well, just you start with alcohol because there's a million drugs that we can talk about. Let's just start with alcohol. What effects does alcohol have on the body?
Liver.
It's a
Kidney.
downer, so
Kidney.
it's gonna relax the
Kidney.
body.
Depression. Agitation. Mood swings.
Heart.
The heart, yep. So we got the nervous system, the liver, the cardiac effects, the
Renal.
renal effects. All right. Oh, what are some priority assessments then?
When's the
Mental
last time you
studies.
drank? Siwa.
Okay, SIWA. Okay. So what's SIWA?
Are they drying from alcohol?
I can't remember the acronym, but yeah, it's used for individuals withdrawing from alcohol, and based upon their score of their tremors and things, that's determines how much Ativan they get to help with their tremors.
I like that. It determines how much out of him they get. Okay. So yeah, so we are definitely going to treat there's different treatment protocols, I guess, too, that you'd have to look at. But safety is the biggest one that we worry about. So you have someone coming into the emergency room, whether they're already highly intoxicated, or they've been intoxicated and they're starting to come down. Safety is always going to be the priority, not just for him or her as the patient, but for us as the healthcare staff. What are some vital signs that we will see when somebody is going through withdrawal?
Tachycardia, increased blood pressure or decreased blood pressure.
Depending on what they used, right?
Yeah, increased temperature, depending. If they're an alcoholic, they'll have low blood sugars, and they'll be really dry, and they'll
Really
need to be rehydrated.
Okay.
They'll have some anemia going on as well, where they have to be on thiamine.
Oh yeah, if they are long-standing alcoholic, right, we're definitely going to have to do full blood panels on them to determine a lot of things because not just their thiamine, but their protein, their albumin, everything can be off.
What about watching like I's and O's? Because if they are like a long-term alcoholic, they could like develop ascites. Like,
Mhm.
yeah, shortness
mhm.
of breath, the whole 9 yards.
Right? Depends. And so, yeah, so obviously it's going to, those are basic and it's going to change depending on what substance the person is coming in and they are, they have used. Biggest thing is, some people are going to be very open and upfront about the amount that they use. Others may deny, right? Oh, this was, I don't ever drink this just, just it's only been a couple times. Some are, like I said, some are going to be more open and honest, others will not. The goal, we want them we really want to determine a pattern of usage, because that is going, to give us a better understanding of what's going on. Somebody said mental health issues. A lot of our mental health, when you look at your schizophrenics, your even some of your bipolars and some of your other more significant mental health disorders, they do tend to move towards the illicit drugs. Anybody know why?
They are attempting to self-medicate. So
With
your
hallucination.
people with ADHD, they're going to start getting a little bit closer to methamphetamines. Um, for whatever reason, they seem to like that. And then people with depression, they're going to start to drink more, and they're also going to be more towards the downers. So like heroin and those things.
Okay. So that is, you're right. That's their way of self-medicating. Because one of the biggest things I'll say is they don't like the way the medications make them feel, right? Or as the alcohol or whatever their drug of choice is, it drowns out the voices in their heads. Um, so if we have somebody that comes in, we're just, like I said, we're gonna stick with alcohol. What are some lab tests that we would do?
Ethanol level, you're going to do their liver panels.
An
Um,
analysis.
to do BMP, CBC. Um, those are pretty much, I think, about it for them.
All right, so what are some priority interventions?
Seizure precautions if they're coming out of, if you're trying to get them sober again. Um, you'll want to do your CWA scales for them if they're a chronic and heavy user. And
Safety.
then rehydrate, but you need to keep them safe, so you'll probably end up with a sitter. So
Yeah, they'll probably be on one-to-one, especially while they're detoxing. We'll give them medications, right? Keep them clean. We also want to get nutrition support, right? They need to have nutrition support. Um, So getting a dietitian in there. If they have liver impairment, right, we have to be careful with our proteins. We also have to be careful with sodium because we don't want them to go into fluid overload. Then, if they, the thiamine supplements, like we said earlier, or somebody, was it Jackie, about, the thiamine supplements for your alcoholics. So it's going to be, yeah, it'll be more specific depending on what's going on with each individual patient. And then, what are some things we want to talk to them about? It's like, oh, yes, you're going through withdrawals. Remember these feelings. What can we do to prevent this from happening again? Right?
Resource.
Okay.
Resources for treatment.
Okay. So, doing the interviews, biggest thing when you're dealing with with anybody really, but with your substance abuse, being non-judgmental, right? Somewhere in the back of their mind, they know what they're doing. right, is hurting their bodies, right? It's really trying to get them to understand the significance of it. Can we recommend therapy and we can recommend them going into detox and rehabs, all of that thing. But just us recommending it's not always going to be, you know, enough. They have to want it, right? They have to be the ones to ultimately make the decision to go into a rehab. Otherwise, they are not going to benefit from it. All right, so what are some potential complications? We're admitting our patient into the hospital with alcohol, and alcohol withdrawals. What are some complications that we may see?
Seizures, hallucinations, aggressive behaviors.
Okay.
Sometimes some organ failures.
Organ failures, okay. Let's see, just with alcohol, how about peripheral neuropathies, alcoholic myopathies, alcoholic cardiomyopathy, gastritis, pancreatitis, what else?
Needing
Alcoholic,
like a
Go to River.
paralysis.
yep. Thrombocytopenia is another one. Even sexual dysfunction is common among your alcoholics. Then we could also worry about with that thiamine deficiency, Wernicke's encephalopathy, or your Korsakoff psychosis, which those are just related to thiamine deficiency. So a lot of times if we replace the thiamine, right, we can reverse the encephalopathy. What if I have a 17-year-old pregnant female that comes in? What are some complications there?
Fetal alcohol syndrome.
Fetal alcohol syndrome, right? That can lead to craniofacial abnormalities, developmental delays, learning disabilities, organ dysfunction in that child. They can also have a alcohol withdrawal delirium. Withdrawal can be fatal as well. And I think a lot of people fail to realize that withdrawals can be fatal. So what are some medications that we can use?
Benzos.
Okay.
Fluids.
Fluids. Okay.
Zofran and Ativan. Zofran to help with the nausea, Ativan to help with the seizures.
Okay.
Hallucinations. You can also do Precedex, but that puts them in the ICU, and that's going to determine their level of care.
Right.
It's kind of gnarly, so I'm going to try to avoid that.
Vitamin supplements, right? Have you guys heard of disulfiram before? What's disulfiram?
Is that the medication that if they drink, they puke?
Yes.
Okay.
Yes.
They're like Vivitrol.
Yes. So disulfiram, it should be started after they have abstained from alcohol for at least 12 hours. And yes, it will cause profuse amounts of vomiting. It's like a hangover times 100. And they can also have like body aches and, all sorts of stuff that goes with the disulfiram. So, that is one of those things that you don't drink alcohol with it. And it stays in the system. So like, it's always, they're like, they want to go out drinking Friday night. They're like, oh, I won't take my medication on Friday. No, if they took it on Thursday, Friday night, that medication is still in their system. Not that we really want them to do that, but it is something that they need to be aware of, that it does stay in their body. It can be very effective if it's used appropriately. what are some teaching that we're gonna do on discharge from the hospital?
Encourage them to follow up at a sober living if that's what they choose to do.
Okay.
Encourage them to quit drinking if they wish to. Try and let them know that if this is going to progress, they're going to cause liver damage and all of these things, but they may not care at that point. If you can, try and get them a ride to their sober living or their their place that they're going to go get clean at. Because
Mhm.
if you don't get them a ride, there's a very small chance that they'll actually go.
Right. Right. You're absolutely right. And even things like, what about encouraging them to, find something else to do? It sounds crazy, right? But, a hobby, relaxation exercises, music therapy, it's kind of distraction, basically what it is, to try to revert that, you know, that energy that they use towards their addiction, try to reroute it into something that is different. Does anybody wanted to be psych or go into this? Yeah, well, Amanda, I 100% had guessed that, but yes. Um, and
I
so,
also think, sorry to interrupt you.
no, you're fine.
I was just gonna say, not in regards to alcohol, but my mom was a lifelong addict and just recently passed away of a heroin overdose. But when she would overdose multiple times in terms of patient teaching, they ended up teaching her about like Narcan administration and like safety with needles and like places to take them and things like that. Because I think there is a point where you can try to, you can lead a horse to water kind of thing, but I was angry that they did that. But it's also like if you know that the person's going to probably continue to do this, giving them the safest options to try to keep them alive was probably the intention with that.
Absolutely. And so there are programs, um, not here, there used to be. I know more so like out west. They used to have needle exchange programs where
Yeah.
they bring in your old needles and that unfortunately as a community health nurse, that might be something that we actually have to teach these
Right.
people is how to clean their needles, how to sterilize their needles. And you're right, it isn't something as a family member, it would probably bug me as well. Um, but at the same time, it's how do we keep our patients as safe as possible, even though we know that they are not practicing safe behaviors, if that makes sense.
Yeah, it's just like a
Um,
different way of thinking about like patient teaching with that stuff because it's not always just like this is what you do and you eat healthy and da da da. You kind of like prepare them for the worst with their decisions.
right, right, because there is only so much that we can do.
Yeah.
And yes, and it's safety for our patients, it's safety for other people as well. So, yeah, but you guys did great. Awesome job. Um, so do you have a couple things that I just want to touch on before since we have what do we have? Well, let me stop. Does anybody have any questions? No. Okay. All right. So this week's reading was chapters 4, 29, and 30. So chapter 4 was about oh Lord. Chapter 4 was about the laws and some of that probably more dry stuff, right? Unfortunately, that we need to still be aware of as nurses, because it can affect us in more ways than we could possibly think of. Um, and so there's a lot of government agencies that are out there. There's So we'll just want to touch up on a couple of them. And so your AHRQ, so I'm sure in some, I want to say it was the med surge text, and I could be wrong with the textbook. The AHRQ is the Agency for Healthcare Research and Quality. They are charged with improving the quality, the safety, the efficiency, and the effectiveness of healthcare. They also help to support research to improve the quality of healthcare, promote your evidence-based decision making. So let's say when you graduate and you go out and practice, I don't know if you've ever heard this, but nurses should always have that questioning attitude, right? Why? That is our job. Our job is to ask why. AHRQ, they do a lot, like I said, with evidence-based practice. So, if you're looking, say you go into your hospital, and you're like, oh my gosh, this procedure for this whatever is just too much. There's got to be a better way, right? Go to AHRQ, look to see what the current evidence or EBP is, what the current recommendations are, and then present it. When I was working on campus, in Norfolk, I met with one of the hiring managers at one of the local hospitals, just having a sit down, like, how are our grads doing, that kind of stuff. And I asked about that. I said, we teach you guys in school, right, to have that questioning attitude, to try to find ways to make things better. And the hospitals do encourage that. Most hospitals do encourage that. So that's a really good research for you, even, while you're, in school still. The Centers for Medicare and Medicaid Services. Have you guys heard of CMS before? Yeah. So in addition to providing, medical insurance, or so to speak, for those over the age of 65, and then of course our lower income and are disabled with Medicaid, they also regulate lab testing, developing coverage policies, improving quality of care. They're also the ones that maintain the oversight, and certifying of nursing homes and other continuous care providers, like your home health agencies, your transitional cares, those kinds of things. CMS is like, they're the overarching, so they're here. And then if you have like Cigna or Aetna, United Healthcare, anything under that, all of them usually follow CMS guidelines. So if CMS says it's okay, usually your insurance company will say it's okay as well. Very rarely do they not. Has anybody heard of OSHA before? Occupational Safety and Health Administration. Their job is to make sure that we have a good, safe work environment. That we have a healthy work environment, that we have the proper equipment in order to do our jobs appropriately. They're the ones that, you'll have your little MSDS sheets, or they call them something else now. And I will forever call them an MSDS, because that is what their SDS is now, safety data sheets. They're the ones that, even during COVID, said that we had to have all the right equipment in order for us to do our job. We look at nursing laws and we look at the Nurse Practice Act. The Nurse Practice Act is there. It is designed with the goal of the safety of the public. Okay. It tells us what we can and what we cannot do within our scope of practice. So whether you're a registered nurse, a licensed practical nurse, it tells us what we can do. There's, I'm trying to think. And then I talked about what negligence was. That's one of the things that I wanted to cover as well. But you did really good with that. When we go to chapter 29, chapter not 29 is the faith community nurse. Who read chapter 29? Skimmed it, browsed it, looked at a couple words in the chapter, read just the title of the chapter. So okay. So our nurses in the faith community, those are registered nurses that have well-developed clinical as well as interpersonal skills. They have strong personal religious faith, as well as a desire or calling to serve the needs of the faith community. And so these, they work within the faith community, whether it's through, whatever type of church it is, right? Could be a church, a synagogue, it can be a temple, a mosque, whatever it is. And they work within, that tight-knit community, to provide, not only, faith, but, all levels of care. So your primary, your tertiary, your I always forget secondary. I always want to go primary, tertiary, secondary. And they'll provide different levels of care depending on what the needs of the congregation are. So they are going to deal with birth, they're going to deal with death, they're going to deal with acute as well as chronic illnesses, stress, challenges from transitions. They also may deal with decisions regarding healthy lifestyle choices. So we look at these, what are some things that parish nurses can do at each level? So primary level, when we're looking at primary prevention, things like, setting up exercise programs or even like group activities, getting the elderly population, or the elderly, folks within the congregation, right? Maybe we can, set up some day programs or some classes that they can come to where they can socialize and they can, um, get out of their houses, get out of their beds, right? Have a little bit of activity. Making sure that they're providing like nutritional foods at church functions, whether it's for, the older people who may not have, the ability to cook those good nutritional meals at home, or if it's working with adolescents who, with a high rate or a high risk for obesity, right? You can use that across both. Your secondary things like going into their homes and doing assessments within their homes. Looking at, I'm trying to think, risk assessments, right? So think of the elder. I always go to the elderly, right? Because they're usually the more vulnerable population within a community. What are the risks for falls? You have some that, they've been married for 50 years, right? And they probably have more furniture than a furniture store in their house, right? So what are some things that we could do to decrease their risk for falls, right? Throw rugs are probably one of the biggest things that we could probably just get rid of, right? Throw them out the window. But at the same time, right, we look at like slick tile floors, right? Anybody have tile in their bathroom, on their bathroom floors? Yeah, have you ever hit that wet tile and like almost just like skated across it? Or is that just me? Right? So, what are some things that we can do? Do they have enough lighting? Do they have electricity, right? Do they have, heat, air conditioning, those kinds of things? Decrease the amount of extension cords Oh my gosh, right? Because as we get older, we need things to be a little bit more bright. And so we start having lights all over the place. Something that I noticed. Actually, I did notice that. And then I had cataract surgery and my whole world just like lightened up a million times. I don't have to have 50 lights on in the house anymore. But right, extension cords or even space heaters, right? Because older people are always cold if they have space heaters. What are some of the things that we worry about with those besides fire? A lot of them now are like, what are they called? When they tip over, they automatically shut off. So, that's pretty good. And then for tertiary, there's still things like, helping them to maintain healthy weights, helping them with stress management, finding ways to help improve quality of life. So your parish nurses can, assess all three levels of prevention when they're working, out in the community. Does anybody know any parish nurses? I know one. I haven't talked to her in a long time. We used to work together, and she actually was in school for, I'm gonna get it wrong, and so it is some sort of a faith-based degree. But her goal was to become a parish nurse, and so she'd been an RN for like 40 years already when I met her. And to her goal was when she retired was to be a parish nurse, which was interesting because this was probably about 15 years ago, but up until that point, I did not know that parish nurses, existed. So I thought that was pretty interesting. And then chapter 30 was all about home health care, hospice, and palliative care. Home health care is pretty broad. It services that we can provide within a person's home. It does, again, all three primary, secondary, and tertiary preventions. It is one of the fastest growing services in the country right now. And so it does have its own definition through the American Nurses Association as well. There's different levels of home health, right? I'm sure everybody's heard of skilled care before. Skilled care services. Generally, it's just a higher level of nursing care. And then, of course, we have hospice and palliative care, which I know I went over those in my lecture. They're different and they're the same kind of. They're both client focused. They all both provide holistic care. Um, but with your hospice patients, they have a terminal illness, right? Much shorter length of time, whereas with palliative services, or with home health, right, it's a little bit longer. Palliative services, they may even be, recover 100%. But hospice, they're usually terminal. With palliative care, we may just be providing, a set amount of services for a given amount of time. So there is a little bit of difference with those two services. And we can provide home health and hospice across the lifespan from birth to death. And so there are pediatric hospice services. I could never do it. God bless the ones that can. I've worked in peds. I've lost pediatric patients, but I definitely could not. I could not do pediatric hospice. That would be a completely different way out of my abilities. Anybody work in hospice or want to work hospice, home health, any of that? No, it's not on our list of things to do. Okay. We also have transitional care, and that's that helps to ensure the coordination and continuity of care as clients transfer between different locations and different level or even different levels of care within the same location. So it's like going from the emergency room to the ICU to, step down to med surge, right? Or going from the hospital to skilled care or a long-term care or even home health. We have those transitional care that is becoming even more important as we go now. Some of our local hospitals are even starting to have transitional care nurses that help them, right, as they transition so they don't get lost in the healthcare system. So they kind of have an idea of what's going on. All right, any questions for me? I just noticed the time. No.